Hi there. Um, I really wanted to do this where I introduced myself before moving into the PowerPoint, but I wasn't able to figure that out. So I want to make sure that you have something visual while we're going through this lecture. Obviously, we're going to be talking about schizophrenia. And then I have a worksheet with some discussion questions just to test your knowledge on the information that we talk about today. There's also further reading, and some of them are videos. I have an ophthalmologist who is studying saccadic eye movements. There's eye movement dysfunctions in schizophrenia, and some training on maybe how to improve that, which was very interesting. It's also very short. And, my schizophrenic life, which is a YouTube channel, which is a father and son talking about experiences. There's also a video on tardive dyskinesia. So you can take a look and see what, a day in the life of having, this disorder, which we'll talk about later. You'll just, none of that's required, obviously, but you can just complete the questions and we'll test your knowledge that way. So let's get into it. There's a lot of information about schizophrenia. Just some general information. It is all-encompassing schizophrenia. It disrupts perception, reason, emotion, movement, and social engagement. So there is not an area in a person's life that it does not touch. Worldwide, schizophrenia affects about 0.3% of the population, or 3 individuals out of 1,000. So it's not necessarily common, but it certainly is not rare. Most cases of schizophrenia are first diagnosed in the mid-20s in men, and later in women, still in the 20s. And then, there's a subset of people, a substantial minority of people who experience a late onset after the age of 40, and that's mostly in women. Males and females are diagnosed pretty evenly, although there's slightly higher diagnosis in women. In order to be diagnosed as schizophrenic, you would need 2 of the following symptoms to be present during most of the time in a single 1-month period. So the symptoms, 2 or more, delusions, delusional thinking, hallucinations, disorganized speech, which could be like word salad, where the sentences don't really make sense, or perhaps that the person is speaking to themselves, or maybe like grossly disorganized behaviors or catatonic behaviors. The grossly disorganized behaviors are going to be maybe childlike behavior, or giggling, or sometimes repetitive motions are considered the grossly disorganized. The catatonic basically means that person isn't moving, and some people will stay in a catatonic state. They just don't move, and they'll be in that state, so let's just say most of the time in one period. That's very abnormal. Or could be negative symptoms that they're experiencing, like blunt affect. Maybe that as flat affect, or a lack of emotionality on the face, or avolition, just a complete lack of motivation. These behaviors can be categorized as positive or negative. So your positive behaviors are behaviors that are not expected to normally occur. People who are on a healthy spectrum do not have hallucinations, nor do they have delusional thinking. I mean, some people have delusional thinking, but you know what I mean. Not to the point of a diagnosis. Negative symptoms occur when normal behaviors are missing. So we would expect that if you are talking about the lottery that you just won, and you won that $1.5 billion lottery, that your face would just show with emotion. sometimes in schizophrenia, they'll have the blunted affect, and even though they're telling you something really exciting, there's no emotion behind it. Or, it could also be the lack of motivation, the abolition. Genetic contributions for schizophrenia. There's evidence that supports a genetic predisposition for schizophrenia. So you find a lot of schizophrenia and psychotic disorders in families in general. The heritability based on family studies, it's estimated to be around 79%. So that's pretty high. SNP-based heritability, when you're looking at phenotypes and the complex nucleotide sequences, according to a GWAS study, is about 24%. So that's much lower. And just so you know, the SNP refers to maybe like a substitution for a C or a G in a nucleotide sequence. So maybe the sequence is supposed to be AACGAT, but the SNP is replacing the C for a G, so it's AACCAT, which is going to cause changes in the phenotype. Maybe the difference in these findings, we really don't understand all of the genes involved in schizophrenia, and it's like a needle in a haystack trying to figure it out. So they can only look at what they think is involved, and maybe we just really don't understand. So that could account for the differences there. One of the most consistent findings in schizophrenia is the presence of dysfunctional eye movements, which can also be found in healthy family members of schizophrenic. So also linked to this dysfunctional eye movement, schizophrenics are more likely to be smokers. Nicotine seems to improve saccadic performance in both patients and healthy controls. So, perhaps the reason why schizophrenics, have a higher rate of smoking, they might be trying to self-medicate with nicotine. Not because it improves the eye motions, but because it provides relief from, more general executive functioning and inhibitory controls. So nicotine can help you focus, and it also has a calming effect. But don't smoke. Environmental influences on schizophrenia. So those can be divided into categories. You have the early development, proximal, and onset factors. So in early development, what we find is that there's a lot of difficulties during pregnancy, like bleeding and diabetes, or perhaps abnormal fetal development, like low birth weight and small head circumference. Could be birth complications, maybe cesarean section, or some cause of lack of oxygen, maybe during the birthing process or in the womb. It could be malnutrition. The mother is malnourished, or that she is exposed to a viral infection while pregnant. So we don't really know why these things happen. So is it the infant's predisposition for schizophrenia that causes the difficulties during the pregnancies, or is it the mother that's having these problems during the pregnancy that's causing a predisposition for schizophrenia, or is it something entirely different? So we just don't know. Some environmental proximal factors of environmental influences include urban living, migration, social adversity, things that cause stress. Rates of schizophrenia are higher in urban environments. It's also higher, 5 times higher in lower socioeconomic groups than in middle or higher socioeconomic groups. So that's a correlation. It doesn't really know. The cause is not known. It could be the inability of people with schizophrenia to hold a job that causes them to be in a lower socioeconomic group with less resources, to be determined. Some of the influence could arise from poverty, crime, poor education, poor nutrition, and stress related to racism, which could explain too why migrants experience substantially higher rates of schizophrenia, because they're probably going to um, encompass, that group, especially if they're undocumented migrants. Some onset factors could be something like a traumatic event that happens. I have a friend whose sister is a paranoid schizophrenic, and she was kidnapped as an adolescent by one of the church members in a church that they went to, and nobody really knows what happened, or my friend's mother doesn't want to talk about it. But when she came back to the house, she came back in a wedding dress covered in crosses that were drawn onto her. So whatever happened, even for a normal, healthy adolescent to go through that, you would have some effects from that. Well, that brought on her first psychotic episode. Cannabis can be another contributing factor. In a study of over 100,000 participants, using cannabis showed that it was a positive correlation with psychotic symptoms, even people who were not diagnosed with schizophrenia. So you don't know if it's causal or correlational. More research needs to be done on that. A shared genetic profile could raise the likelihood of both cannabis and the use of schizophrenia. It is associated with more relapses, hospitalizations, and pronounced psychotic symptoms in patients. And it is also associated with earlier onset of schizophrenia. And maybe some of this is because patients with schizophrenia, or a variation of why it might affect greater, schizophrenic patients have higher levels of cannabinoids in their cerebral spinal fluid and increased cannabinoid receptor density compared to healthy controls, regardless of whether they've used cannabis or not. We can't be in biopsychology and not talk about brain structure and function. So schizophrenia is associated with smaller intracranial volume, total brain volume, and gray matter volume. So the largest difference is observed in the volume of the ventricles, which are enlarged in schizophrenia. PET scans and SPECT scans indicate that people with schizophrenia demonstrate hypofrontality. So that's going to be hypo, meaning less, so lower levels of frontal lobe activity than healthy controls. And that's during rest and doing difficult cognitive tests. And, if you want to, you can look in the book in the schizophrenia section under the brain structure. It's very interesting to look at a brain scan of like a healthy patient versus the schizophrenic with that hypofrontality. So in evaluations of resting state, fMRI, patients with schizophrenia demonstrated large-scale decreases in the connectivity of many essential networks. So we'll kind of talk about a little bit later the dopamine hypothesis, and then, how science is kind of coming to the fact that there's probably many networks that are affected by schizophrenia. Why is it such a late onset? You would think that with the, schizophrenia, probably the likelihood of having schizophrenia has happening in the womb. So that early development piece, you would think that, we would be able to diagnose this a little bit earlier. So there have been studies done on this, and they found that following healthy controls and, schizophrenics through, when they're actually diagnosed with schizophrenia, it shows a steady declining IQ from age 18 months to 20 years. So there are clues, but you wouldn't necessarily know that it's schizophrenia until they meet, those two symptoms in the 1 month period. So children typically experience a burst of cortical thickening at puberty, followed by a period of cortical thinning extending into the early 20s. So that's that brain development, the natural progression of it. And the thinning probably represents changes in dendrites, dendritic spines, and myelin. Healthy teens experience relatively little thinning, while teens diagnosed with schizophrenia experience a lot. It's a tremendous loss. And I wanted to show a photo of that from the textbook. You can see that the normal cortical thinning, it's just a little bit in typical adolescence, but in schizophrenia, it's really, really, it's a lot. So the biochemistry of schizophrenia, going back to that dopamine hypothesis, basically it was thought that dopamine, in schizophrenic patients, they produce, synthesize, and release more dopamine. So they thought that, oh, well, this is the dysfunction. It is actually the increased volume of dopamine produced by schizophrenics. And, there's a lot of supporting evidence for that. For instance, some dopamine agonists, amphetamines, cocaine, and L-Dopa, which is used to treat Parkinson's disease. These drugs can produce positive symptoms like schizophrenic symptoms, like hallucinations and paranoid delusions, and dopamine agonists, antipsychotics, which act by blocking the D2 dopamine receptor to reduce psychotic symptoms. Also work with the stimulants as well to reduce psychosis in people taking amphetamines and cocaine. And again, the people with schizophrenia are demonstrating the greater dopamine synthesis and release, which is in the mesolimbic pathway connecting the ventral tegmentum and the nucleus accumbens. But the dopamine hypothesis is too simplistic. And we'll go through a few reasons why. It could be that there is a dysfunction in the glutamate system, which is causing the increase in dopamine synthesis and release. So a disruption of glutamate signaling in pathways linking the cerebral cortex to the ventral tegmentum might result in the overaction of these dopamine circuits. People diagnosed with schizophrenia have reduced numbers of glutamate receptors in their brain. So they did some animal models to create schizophrenia-like symptoms in monkeys in the lab, and they used phencyclidine, PCP. It is a glutamate antagonist. So that's going to produce those schizophrenia-like symptoms. The PCP blocks the NMDA glutamate receptor, and it also serves as a dopamine agonist. So that kind of tells you that the glutamate system, glutamate circuit, might have something to do with why there is more dopamine in the system released. Glutamate disruption may also be influenced by serotonin activity. And how do we treat this? The first antipsychotics were the phenothiazines, including chlorpromazine, which you probably know as Thorazine, which is still in use today. I looked it up. This was discovered by Henri Laborie. He was a French surgeon, and he noticed that in his patients after surgery, that the phenothiazines had a calming effect on them. And he, being a very smart guy, thought of his psychiatrist friends who are treating people with psychosis, and he thought, well, if it's having a calming effect on his patients, maybe it would be an effective treatment for psychosis. So further research found that these antipsychotics were effective in treating the symptoms for schizophrenia. They were effective in reducing positive symptoms. They do not reduce negative symptoms. In fact, in some cases, antipsychotics have been known to create secondary blunting affect. So that's the lack of emotionality. So they could actually even worsen negative symptoms. One of the side effects of long-term use of antipsychotics is tardive dyskinesia. Tardive refers to slow, and dyskinesia means difficulty moving. Oh, there's my dogs. Hi, Bailey. Hi, Jack. Patients experience tremors and involuntary movements, especially in the face and tongue. And I did include a video in the further reading that just shows you how devastating tardive dyskinesia can be. It's really known what the exact cause of this is, but researchers do have an idea. So voluntary movement requires a balance between activity in a direct pathway connecting the basal ganglia and the thalamus that facilitates movements, and also in an indirect pathway that inhibits movement. So activity at the D2 receptors inhibits the indirect pathway, so that's going to make movement more likely. An increase of D2 receptor density in response to the prolonged use of the medication could result in involuntary movements. Also, chronic blockage of the D2 receptors might distort the balance between direct and indirect pathways, which may be stimulating a maladaptive plasticity in connections between the basal ganglia and cortex. There's actually a study done on some cloistered nuns, and the researchers ran some scans on their brain and found that, even though these seemingly healthy individuals who were able to critically think, still able to function normally, actually had the brains of what looked like moderate to advanced dementia. So that would be an example of how plasticity can work in the connections in your brains. Unfortunately, in this situation, it's maladaptive. It could be due to oxidative stress, due to the increased turnover of the dopamine, which in turn increases the production of free radicals and hydrogen peroxide. So, it's just more kind of like trash for your body to get rid of. And that could also contribute to tardive dyskinesia. There is a second generation of antipsychotics out there, and a lot of people are taking them. The newer medications have been known to reduce both positive and negative symptoms, but they're not necessarily safer. They can produce weight gain and diabetes in a lot of patients. They can also have adverse effects on the immune system, and they still carry about the same risk of producing tardive dyskinesia. My friend with the sister with paranoid schizophrenia is on some of these second generation antipsychotics. She is diabetic. She experienced weight gain, and it did have an adverse effect on her immune system. She actually passed away from complications due to COVID this past year. So, and these drugs are so hard on your body. Although the side effects can be avoided in most cases by careful monitoring by the doctor. What else helps? So psychosocial rehabilitation can be very helpful when you teach life skills, training, education about schizophrenia and the importance of medication, provide affordable housing, link to services in the community, and information about symptom management. All of these things can ensure that our schizophrenic patients have a place to live off the street with the support that they need. Unfortunately, that's not such the case in some of the more developed countries. The WHO published a research recently suggesting that patients with schizophrenia in developing countries like Nigeria, India, and Colombia were recovering more frequently than patients in wealthier countries. So we have to do better. Well, that is schizophrenia. I have the discussion questions for you to answer. All the information can be found in this PowerPoint. I'm going to try to download it. I had such an issue with that in another one of my classes, so hopefully that won't be the case here. I hope you all enjoyed my presentation. Thanks for listening.